Good afternoon, ladies and gentlemen. We're delighted you're with us today. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council. We want to thank you for attending this educational webinar today. It's hosted in coordination with Forvis Mazars. They're an associate member of the DFW Hospital Council and have been a friend and valued colleague of the council for many years. Today, we're going to talk about the One Big Beautiful Bill and the future of healthcare. Now, we're going to talk specifically about some of the components of the One Big Beautiful Bill, but then we're also going to talk about some things that are going to impact providers that aren't necessarily in the One Big Beautiful Bill. We're delighted that we've got an excellent expert with us today. His name is Chad, and Chad has been with Forvis Mazars for a few years. I met Chad Mulvany when he was at the California Hospital Association. He now has joined Forvis Mazars as their Director of Healthcare Consulting. And trust me, he is a book full of knowledge. He knows healthcare policy. I'm going to ask him some questions. We're going to follow an outline. But at the same time, I'll add a little color from a Texas perspective. But the thing we want you to do is sit back, listen, enjoy. We know some of you are not necessarily involved in healthcare day in and day out. So we're going to try not to get too technical or too into the weeds, or at least we'll explain some of the things we're talking about. You know, Chad Mulvany, as I said, has been dealing in health policy for a number of years. And I was chatting with him just a few minutes ago. You know, when I look at the big, beautiful bill, it reminds me, because I'm an old guy, of 1997 when the Balanced Budget Act was passed and there were significant reductions to Medicare and Medicaid. And then in 1999 and 2000, Congress realized this and they restored some of those that they had basically reduced a couple of years earlier. So it's going to be interesting to see if history repeats itself. Now, if you have questions, feel free to put them in the Q&A. If we don't get through all the questions, we're going to have our email addresses up at the end of the presentation so that you can email Chad or me and we'll try to respond to your questions. But Chad, let me just say welcome, and we can jump right into it unless you have any opening remarks.
No, well, Steve, thank you first for the opportunity to be here. It's certainly an honor. And two, thank you for the very generous introduction. I wish there was some way I could print that out and put that on the fridge.
Okay. All right, well, we're going to jump right into the One Big Beautiful Bill. And I want to ask you something. We've heard a lot about work requirements. What do you think about what's in the bill on work requirements, and do you think will affect Texas?
Yeah. So, beginning December 31st of 2026, the bill requires beneficiaries aged 19 to 64 to engage in work or qualifying activities. So that's community service, education, jobs, training for no less than 80 hours a month. And it exempts certain groups of individuals that you would anticipate: pregnant women, parents of children under 14, guardians of children under 14, the disabled. So when you start to think about Texas, because Texas is a non-expansion state, I think it's something to monitor and certainly something to help educate your Medicaid population about. But when I think about Texas, my picture of the world is that you don't have a lot of 19 to 64-year-olds that wouldn't fall into one of those exclusion categories running around. But again, that's kind of my view from the outside. I'd be curious as to your thoughts.
You know, I totally agree with you. You know, a lot of people don't realize when I talk to people, they say, well, Medicaid really covers people that live in poverty. And I said, no, in Texas, generally, as you indicated, you have to be pregnant and you have to either be in a postpartum for 12 months, a child, you have to be disabled, or in some cases, seniors that would be in certain skilled nursing facilities. So I totally agree with you, Chad. I think the work requirement, really, most of those people are going to clearly get exemptions.
And
You
the
know,
other
it's
thing to
enough.
think, whoops, sorry, the other thing to think about is for that maybe small sliver of the population that might be impacted, clearly they'll fall off the Medicaid managed care organization's rolls, but then what the impact will be on uncompensated care, your disproportionate share, patient percentage, is a bit of a question mark because I don't tend to think about people that fall into that 19 to 64 that are outside of that exclusion of being frequent users of healthcare services. So you may see some drop off in ambulatory activity if you're a safety net provider. But the question then becomes for that very small sliver, how long before, if they have a chronic disease, do they end up with it going unmanaged and them showing up in your ED?
Totally agree. Well said. Another component of the bill that now is passed, it's the law, of provider taxes. The one thing I'll say about provider taxes, 49 out of 50 states use provider taxes. Alaska does not, but they have been around since the 1980s. And provider taxes, some have labeled as money laundering, a Ponzi scheme. They've been vetted at the federal level and the state level. So I just want to kind of move that notion away that this is some kind of trick play that we're doing. So what are your thoughts on Texas and the provider taxes, all the provider taxes nationally?
So, and you're right. The provider taxes, particularly as at least most of the states that I'm familiar with, you've seen very little increase in their fee for service Medicaid rates, which is translated into the managed care rates, because typically most states kind of have a ceiling or a floor, depending on how you want to look at it. So even if you're out of network, that's the most the plan's going to pay. Between that, it's been an important way to kind of help on the back end provide supplemental payments that keep hospitals and particularly safety net hospitals afloat. Unfortunately, the one big beautiful bill for non-expansion states like Texas freezes it. So as of date of enactment, for non-expansion states, starting in 2028, it steps it down by half a percentage point until it reaches 3.5% in 2032. The thing for non-expansion states to remember, and this was an important carve out, is that for the expansion states, it carved out nursing homes and intermediate care facilities, so they'll still in those expansion states be able to use provider taxes at current rates.
That's a very good point. And many of the local and the state provider taxes in Texas, thankfully, were at the 6%. So you're right. As we look at some components of this as we go forward, they may be phased in later, but I'm hoping that we can preserve that 6%. Very good point. There's
and
another
again,
thing.
because Texas is a non-expansion state, they just get frozen in place. So it's a benefit.
That is definitely a benefit. Another thing, state directed payments. I know some people here may not understand it, but the state directed payments in Texas is a very complex thing, I can assure you. Do you have any general comments on the one big beautiful bill and state directed payments?
I want to just start kind of where you did on provider taxes and maybe trying to debunk some of the myth around it that was used to kind of put them in an unfavorable light. And a lot of those that were in favor of reductions to state-directed payments or caps on state-directed payments cited the growth over recent years in SDPs as a problem, but I think it's a natural response to the shift to Medicaid managed care. Because as you pulled more people out of fee-for-service, you pull more dollars out, or fewer dollars are available for UPL through Medicaid DISH. So we needed to find another mechanism to, again, make the payment adequate. The bill for state-directed payments upon enactment, so as of July 4th, caps SDPs at 110% of Medicare for your non-expansion states like Texas. For expansion states, it's 100% of Medicare with a grandfathering clause. So for preprints for which prior approval or a good faith effort were, as determined by the Secretary, made by May 1st of 2025, they're grandfathered. Rule SDPs, again, either approved or good faith by the Secretary, which were made by enactment for the rating period occurring within 180 days are grandfathered, or STPs for which a completed preprint were submitted to the secretary prior to enactment. And so if you're grandfathered, you basically are locked in place at what you've got until January 1 of 2028, and then they reduce it down by 10% per year until you get to, and that's January 21, 2028. It's beginning there, or the rating period that begins thereafter. And from there, your SDP is reduced by 10% until you hit whatever that percentage of Medicare is, depending on whether you're expansion, non-expansion. The key question for me is around some of these terms for grandfathering. So, what is a completed preprint? What is a good faith effort? One of the things that I've also thought about and had some concerns of is if you look at, there is in statute a way that you can get a state directed payment program for up to 3 years. However, most are approved for exactly 1 year. My understanding is that they'll consider anything that's been approved for 1 year, and if you're not making changes to it, it'll be considered an existing, so it'll just continue to be renewed until you hit that grandfathering, the end of the grandfathering period. But it's still certainly an open question that I've thought about.
That's a real good point. And, for the benefit of the people that have joined us, state-directed payments. Let me give you just a little bit of flavor on Texas. It's very complex, but really they were to improve access to care, promote quality initiatives, and really address state priorities within the managed care for Medicaid. And state-directed payments are really financial arrangements where states direct their managed care organizations managing Medicaid specific payments. Now, I'm not going to get into the weeds, but it gets into what's called CHIRP, TIPS, and RAPS. CHIRP is Comprehensive Hospital Increase Reimbursement Program. It then drops down into 3 different components. As you just heard Chad say, we're a non-expansion state. We're looking at 2028, it's going to be capped at Medicare at 110%, and then we're going to basically come down. I do have 2 comments, though. I want to give credit to Executive Commissioner Young from HHSC. She is very conscientious. She interfaces and works and represents Texas with CMS, and at the same time, she has her directives that come from the state legislature and, of course, from the executive branch. And at the same time, she tries to balance that and be fair to providers. And I think she has been extremely conscientious in looking at state-directed payments. Texas is very complex the way we did it. A lot of that because we didn't expand Medicaid. And I think as we move forward, she's going to probably help get answers to some of those questions that Chad just brought up. And the final thing I want to say, I talked to Stephanie Carlton. Stephanie Carlton is the chief of staff for Dr. Oz, who runs CMS. I know Stephanie very well. She was at McKinsey here in Dallas. She left to go work for Dr. Oz. And I talked to her several months ago, and I said, what do you think just the burning big priority Dr. Oz has? She said value-based care. I would not be surprised as you look at state-directed payments, and especially in the future, if they aren't wrapped around quality initiatives with value-based care. We'll have to wait and see. Do you have any other comments related to that, Chad, on the state-directed payments?
I don't, but I do think that your point about kind of digging in deeper about the reasons why we have them, access, quality, are incredibly important as you think about, because this is typically not just money given to providers. It's money that's given to providers for a very specific purpose. And the quality metrics that are put into these programs where they exist are pretty stringent, and they're aligned with the population. So it's paying for an outcome.
The other question, and this is kind of an unfair question, but Chad, this is going to be delayed 2 years. So if funding is coming in and, needs change and priorities change, is there a chance some of these funds could be directed to other things?
Are we talking about like the Rural Health Transformation Program or just in general?
just in general, the timing of some of the components of the bill, some of the reductions are delayed 2 years. So states may use some of that funding for other purposes.
It's an open question. It's a good one, and it's certainly something that bears watching. But the other thing to remember is, with all 50 states, kind of like healthcare markets, if you've seen one, you've seen one. So how a
Right,
certain state chooses to behave is will, kind of have to follow your local market.
right. Well, you mentioned the Rural Health Transformation Fund, and I think a lot of people probably maybe followed this or didn't, but a lot of the rural hospitals are supported by Medicaid. A lot of the rural hospitals have very thin margins. And so they added to the final bill that was passed a transformation fund of $50 billion. Can you explain a little bit about that and your thoughts on it, Chad?
Yeah, and just kind of as a framing statement, in my mind, this $50 billion should have come 10, 15 years ago, because we've been able to clearly see the demographic trends, people aging into Medicare, people moving out of rural areas, that have pointed to the fact that it would become harder and harder to sustain the rural healthcare delivery system as it's currently configured. And these communities need some help sort of getting the delivery system optimized for the population that it has. So the fund provides, as you mentioned, $50 billion over 5 years. Some of it was intended for transformation. Some of it, depending on who you ask, was intended to fill the gap in funding taken out of Medicare or Medicaid, sorry, through the OBBA. The money will be allotted between 2026 and 2030 at $10 billion a year. Each state will have to apply for its allotment. It's a one-time application. And if you're not approved, you don't get funding, you don't get another opportunity. Assuming all states are approved, the first tranche of the money is spread equally. So in theory, all 50 states would get $100 million. That's the $5 billion that gets allotted equally from 1 year. The next half of it gets allocated based on a formula that's in statute that would take into account the proportion of the state's or population that's rural, the percentage of the state's providers that are rural, and the statute defines what a rural provider is for this purposes relative to the national total, and also the quote unquote situation of the state's dish hospitals, plus other factors that the CMS administrator may take into account. Just a couple of thoughts on this. Obviously this money is needed, but when you think about Kaiser Family Foundation's analysis suggests that there's 137 billion in Medicaid funding that comes out of rural areas over 10 years. This is 50 billion, so roughly 37% of what's coming out is going back in. So not clearly going to be adequate to what's lost. The other thing to kind of understand is that it will be up to states as to how they will use the funds, and the state application process requires the state to provide a fairly detailed transformation plan for rural areas, and then lists out a fairly long list of uses that states must choose at least 3 of. This includes managing or preventing chronic disease, providing additional payments to providers, implementing different technologies to either improve the efficiency of care delivery or to improve outcomes, investments, to your point earlier, in value-based care, so things of that nature. But one of the things that I think folks need to think about is that it's not guaranteed that a specific provider type will get funds. Just because there's that list in there, that list is for allocation purposes only. It will really be up to the state, their transformation plan, as to how the money's used, who gets the money.
It's really, really valuable information there, Chad. The only thing I will offer, for the people that may not have thought through, the first part of this formula is allocated equally among the states that are participating. That's a big disadvantage to Texas because we have such a large state and we have so many rural facilities. So Connecticut is going to get the same allocation we get. So that's a disadvantage. The other thing that I think you mentioned that was very important that came from the Kaiser Family Foundation, this will give back about a third of that gap that's created. And I was talking to someone the other day and said, Steve, I don't mean any offense, but I'm not on Medicaid and I feel sorry for the Medicaid cuts, but it doesn't really impact me. And I said, Yes, it does, especially if you live in an area where a provider has to cut back a service or even close. For example, labor and delivery. If they close it, that's going to impact the whole community. And they went, I hadn't really thought of that. So I totally agree with you. We've got to do everything we can to support all hospitals, but especially our rural hospitals.
Steve, just
You,
to kind of, you're making great points, and a couple other things to add to this. So by December 31st, the CMS administrator has to have processed applications. What I have heard is that, and certainly Dr. Oz in the round of the Sunday shows, I think 2 weeks ago now, suggested that the application would be out by early September. I
right.
think it's important for providers to start thinking about a couple of things, right? One, start working if you haven't already with your state associations, your federal legislators. If you have contacts at CMS, talking to them about what you'd like to use the money for, how you think the money should be used. And what I would suggest to you is you think about kind of what you might ask for, either in the pre-application process or after the state submitted an application, you're thinking about your allocation. I am highly suspect that a state will allocate that much money to just sort of backfilling provider payments, because this is a time limited fund. And while I might be willing to bet a paycheck that Congress, when this fund runs out in 2031, might add more money to the pool, I don't know if I'd bet my rural health area if I was a state, or my organization if I was an executive on that. So again, understanding that very little of that money, I think, will be used for propping up payments, I would look at my strategic plan, and I would look at the things that I need to invest in to achieve those goals that are aligned with some of the questions that the state will have to respond to as part of its transformation plan. And I'd start looking at the uses of funds that a state could make. And I'd also think about some of the things that Dr. Oz and his communications over the course of his tenure now have suggested that he's supportive of: telehealth, remote monitoring, chronic disease, value-based care. Create a Venn diagram, see how much of that is aligned with your strategic plan, and start crafting your narrative now about how you would use those funds. And even, as you think about it, and as you get a better understanding of what the state applies to CMS for, what the state application process is, continue to refine that argument, start to put numbers to it about what an investment in terms of an ROI will get the state and CMS.
Good points, Chad. Another thing, this is increasing the deficit. And there's something that's usually waived, but there's no guarantee, called PAYGO and sequestration. Can you explain to the people that are on this the deficit that we're facing? What could it trigger, and how would it impact providers?
Yeah, so there's something called the Budget Control Act, and within it is the S-PAYGO sequester. And this is just different than your vanilla 2% Medicare sequester that CMS applies, or that Congress applies every time it needs to do the extenders in a year-end healthcare bill and it needs an offset for it. And essentially what the S-PAYGO sequester is anytime there is legislation passed that increases the deficit, and HR 1, the One Big Beautiful Bill, increases the deficit by $3.4 trillion, the Congressional Budget Office there is a requirement that the S-PAYGO sequester take effect. For Medicare, it's capped, so it's capped at 4%, but that would be a 4% cut on top of 2%. Now, the reason why some folks aren't familiar with this is every year historically that we've encountered this situation, Congress has stepped in to, quote unquote, wipe the PAYGO scorecard clean. And this is something that they typically do in the federal funding bill before the new Fed fiscal year takes into account, so the cut doesn't take effect. Again, I've said Congress historically does this. I think this is something to watch when Congress returns from its August recess and they start to really roll up their sleeves and figure out how they're going to fund 2026, that fiscal year, because this will be part of the debate.
Right. It's an excellent point. One other thing that's touched in the One Big Beautiful Bill deals with Medicare savings plans and people and individuals that are enrolled. Is this going to impact how they do that?
It will. And so there was a rule finalized by the prior administration which made it easier for Medicaid beneficiaries to enroll in Part B and get subsidized Part B coverage. The Big Beautiful Bill Act repealed that rule, And so it will have an impact on that. One of the things to note is this isn't something that you'll see as a reduction in kind of your income, your revenue, because many of the deadlines that states were required to meet have not passed yet. So states hadn't fully ramped up and implemented it yet for most places. But it is something that will kind of be a drag that you didn't anticipate on revenue, that will be a headwind that maybe wasn't there before One Big Beautiful Bill Act was passed.
Right. Good point. You know, I think we've covered almost everything. There's one other thing that's going to definitely impact Texas hospitals and other hospitals. We get what's called Medicaid disproportionate share payments. And there was going to be a delay in some of those reductions, but it's not in this bill. It was in the House version, but it was not in the Senate version that finally went through. I can tell you for Texas hospitals are going to lose in 2026 $778 million. So over a 3-year period, that's going to be, over $2 billion. What are your thoughts on those Medicaid disproportionate share reductions, and not only for Texas, but for other states?
This to me is one of the quote unquote canaries in the coal mine that I'm watching, because as you sort of alluded to, the 1997 and the 99 and 2000 legislation that basically repealed the cuts. The Medicaid dish cuts were a pay for the Affordable Care Act that Congress since 2014 has been kicking the can down the road. My question, or the thing that I'm watching, is, and it's not a guarantee, right? If they delay the cuts again, it's not a guarantee that they won't let the OBVA cuts kick in, but it is kind of an indicator of, if you can't cut Medicaid by $8 billion nationally, how are you going to cut it by $100 billion a year nationally? So I think that is something that would be important to watch. Again, I think it's hard to prognosticate at this point as to whether those cuts get kicked further down the road. Again, like I said, been done every year since 2014, but I think kind of like your investment portfolio, past performance is not guaranteed a prior or future performance.
Yeah, that's a very good point. Just to help our audience put those in perspective, I looked Medicaid dish cuts in District 12, and that's Congressman Craig Goldman, will be about $5.9 million out of that 778 million that I mentioned. In District 19, Representative Jody Arrington, it'll be over $34 million. Representative Julie Johnson, and by the way, this is all bipartisan. We're not going red or blue. We're just going facts. And for Representative Julie Johnson, District 32, it's going to be 2.8 million. For Representative Mark Vesey, and he's in District 33, it's going to be 41.9 million. Representative Keith Self, which is in District 3, it's going to be $4.6 million. And Representative Jake Elchie, it's going to be 24.7. The point I'm trying to make is this is going to affect hospitals in all congressional districts. And of that $778 million, it's going to impact us. I want to switch gears now a little bit, if I could, Chad, and let's talk about some other things that are brewing, things that potentially could impact hospitals. The first one, let's kind of kick off 340B. And for the people that are on the call that don't normally deal with 340B, it's a federal program primarily designed to help Safety Net and other hospitals get drug discounts related to medications. So when we say 340B, we're basically talking about prescription drugs that providers can get discounted drugs. So let me stop there. And I know you've done a lot of work on this, Chad. I think Senator Cassidy has done a lot of work on this. I know you've looked at it. What is your thought on what's going to happen in 340B?
Yeah, I think before I get into my answer, one other important thing for those who aren't familiar with the program, 340B does not cost the Treasury money. I mean, it may to the extent that there's some foregone tax revenue that pharma manufacturers would have paid, but it's not like it's coming out of the Part A trust fund. It's not like it's money coming out of the general fund. It is a discount off of revenue that pharmaceutical manufacturers give to providers. And one of the reasons why it was expanded during the Affordable Care Act is it was part of the pharmaceutical pay for the coverage expansion, right? If you think about it, providers took the productivity cuts along with a couple of other things. You saw the plans accept MLRs. This was kind of their version of a pay for it. You mentioned Senator Cassidy. The reason why he is important is he is the chair of the Senate Health, Education, Labor, and Pensions Committee. That's the committee of jurisdiction in the Senate. Senator Cassidy has expressed some concerns about misuse in the 340B program by covered entities. And he believes that this misuse is resulting in cost shifting to the private sector, which is increasing drug prices to employers in the large and small group markets, as well as those who buy on the individual market. And maybe this is a bit flip, but I'm glad he believes that there is such thing as a cost shift. But before we talk about the drug price cost shift, I'd like for him to address the Medicare and Medicaid cost shift and the impact that that has on commercial prices. With that sort of soapbox moment aside, earlier this year, he put out a report that highlighted some issues that he believes exist in the program and suggested solutions. And those solutions were more or less pieces of or policies that were laid out in other pieces of legislation that had been put forth prior Congress and so I think it's important to kind of think through that and monitor that. The three bills that I think are worth watching from the prior conference, obviously you've got Representative Masui's Patients Act, which generally I think the provider community would embrace or does embrace. It essentially codifies in statute the sense of Congress as to what the 340B program is intended to do, which is stretch scarce federal resources so that providers can maintain access for safety net populations. And then it also clarifies in statute that the 340B discount should be available for qualifying drugs dispensed through contract pharmacies. That's already been reintroduced in this Congress. Another bill to watch would be what was put forth by the Senate Gang of Six last Congress. There's a new Gang of Six now because some folks have moved into different roles or retired. And the Gang of Six bill is what I've kind of thought of as a facts of life bill. To the good, you take the good, you take the bad. To the good, it has the contract pharmacy language that we like. To the possibly bad was a blank section in the draft bill released last year that may be redefining what a 340B patient is and narrowing that definition in a way that might limit access to the discount for certain drugs in certain populations. One of the hangups, one of the reasons why it was never formally introduced is with the draft bill that was released, I believe it was last April, right, was basically a request for information that hit a number of different topics. One of them was, how should we define patient? Because that section was blank. My guess is that they could never reconcile what they heard from providers, covered entities with what they heard from manufacturers. Even through the very end of last year, I kept hearing that this was going to finally be released, never happened. They're still working on this, so we may see this later this year. Last thing I would flag is the 340B Access Act, which was now retired Representative Bouchon from Indiana. Possibly Representative Spatz from Indiana may pick the legislation up. The thing, lots concerning in the bill, but one of the things that I think was most concerning is that it would change the qualifying criteria for the program, pull in data that much of it today is not reported on the cost report, not reported to HRSA, so it would be difficult to model. But even just kind of back of the enveloping it, what some analysis would suggest is that many of the hospitals that gained access to the program through the expansion of the ACA, the expansion of the program in the ACA, would lose it. So that's also, if that gets reintroduced, that will also be another important bill to watch.
And to tie into this, and I know we're getting a little in the weeds, so I'm trying to keep it where it's not, but a lot of the issues related to 340B occurred in 2017, as you know, Chad. And when those issues, we felt like providers got underpaid. And then CMS came back and upped some outpatient payments. And now they're proposing what we refer to as the ops rule, where they're going to do a clawback. And what hospitals thought was going to be recouped over 16 years, they're condensing the 6 years to claw back some of this funding. This even went to the Supreme Court, if you remember back during all this legislative disagreement. But now they're throwing in things like same-site neutral. For people that don't know what same-site neutral is, it's essentially saying, regardless of where the service is provided, in a hospital, in an outpatient setting, in a surgery center, all the payments should be the same. Well, the acuity level of the patient could be much different. So providers aren't exactly in agreement with that. With that said, and with that kind of messy background I gave, what do you think about this ops rule accelerated the clawback and how it could impact providers?
Yeah, no, so there were a number of things in the ops rule, the OPPS rule, that are concerning. You hit on one of them, taking that reduction or that clawback from a 0.5 percentage point over 16 years to 2%. My sense is that CMS will finalize that as proposed. And so again, we'll take the payment update, and for many providers will be barely over what they received in 2025. And for some, depending on where you are and what your budget neutrality adjustments look like, could even be negative. I don't know this for fact, but my guess is that as soon as we get into 2026, when you can actually show harm, someone will challenge the recoupment in court. I'm not an attorney, so I can't speculate on the merits of a potential lawsuit, but I think that's something to watch. The one thing that I would say, though, as someone who may be on the receiving end of this recoupment, even if it goes into court, I still think you have to prepare and figure out how to right-size your cost structure to account for it. Because if the court case is successful, congratulations, you managed to improve your margin. If it's not successful, you're prepared for it. The second thing you touched on, or the second thing related to 340B, is the survey. And so you mentioned the Supreme Court case. The last time that CMS attempted to implement a reduction in reimbursement for separately payable Part B drugs that were required under the 340B program, AHA challenged it, ended up in the Supreme Court. And what the Supreme Court found was the fact that CMS doing this in a budget neutral manner wasn't impermissible. What was impermissible is the fact that they took the discount factor, the 28%, which got you down to ASP minus 22.5. They took it, I believe, from a MedPAC study and just plugged it in, whereas the statute says you've got to have data, you've got to use the data that you collect. So now in the rule, they have laid out a timeline for administering this survey. You may recall that CMS attempted to execute this survey, field this survey, in the spring of 2020. I vaguely recall from the spring of 2020, we were all doing something, working 16, 20 hours a day trying to keep hospitals open because of a pandemic. So there was an incredibly low response rate to this survey. And CMS found they couldn't use the data because it wasn't statistically valid. They address a lot of that in the proposed rule. And they talk about how, if we don't get a sufficient sample size, one of our strategies may be is we may look at the hospitals that don't respond, kind of tranche you out based on some demographic characteristic, or segment you out based on some demographic characteristic, and then assign you the lowest cost from the hospitals that are like you that respond. Obviously, that would put incredible downward pressure on the actual discount rate. The other thing they talk about doing in the rule is potentially making the assumption that if you don't report, you may have de minimis drug costs. And so therefore, they might just start thinking about their separate, or their packaging policies in OPPS, and they might start doing more packaging. So I think that is something that is concerning. Last thing you talked about was site neutral for drug administration services. Again, CMS implemented, and I want to say it was 2018 or 2019. My memory is a little foggy going back that far. A separate payment policy for clinic visits. So essentially what they said was, any of the accepted off-campus HOPD clinics, we're now going to pay you at the physician equivalent amount for those services, which is 40% of the OPPS schedule for that CPT code or for that APC. And that is permissible. That was challenged in court because they did it under something called a budget control method, which is where CMS sees an increase in volume for services. If they think it's something, if that increase is directly related to payment policy, they can make a reduction. It doesn't have to be budget neutral. Same thing again around separate drug administration services. So, and I think that's on pretty good legal ground, given that it's been challenged in court once. So I think that's something to think about. I guess just as a general kind of concept on site neutral, you touched on a very compelling argument as to why site neutral payments for hospitals is inappropriate, right? When you look at the data, patients treated in hospitals tend to be sicker. They tend to be more complex. Hospital outpatient departments are subject to far more regulatory requirements. But the premise underpinning site neutral payment policy, even before you get to those three facts, is the fact that Medicare pays physicians through the physician fee schedule appropriately. Between MACRA, between the SGR, I don't think that's true. I don't think there are very few people that I think would stand up and tell you that that's true. We see MedPAC suggesting that we need to start paying physicians more. Congress is worried about it. We've seen physicians vote with their feet and leave private physician-owned practices and go into different models because they can't make ends meet. So I'm not sure site neutral is an appropriate policy for the problem that they're trying to solve.
Yeah, those are excellent points. What I'm trying to do is we've covered a lot of the points of the big, beautiful bill. And, on the Medicaid part for Texas, it could have been a whole lot worse. I'll be the first to admit that. It's still going to be bad, though, because of what we talked about on rural hospitals, especially, and also on the DISPRO, unless we can remedy somehow the DISPRO. But I want to move on to something now, Chad, that I personally think could impact Texas, and it could be a big negative impact. And let's talk a little bit about the exchanges, the exchanges we have out in the market, and I'm going to break it down into a couple of areas. We can talk about the enhanced premium tax credits first, which is very important. But then I want to talk about the timing of, we're in August already, and some of the insurers have already put their preferred rates, and it's going to be some significant rate increases. So all of this is going to tie together. But let's first talk about people that in Texas, there are 3.4 million people that are currently using enhanced premium tax credits to help them secure health insurance out in the individual marketplace. If those are not renewed by Congress, there are estimates that 1.7 to 2 million people could quickly become uninsured in Texas. That is a tremendous number. That would be more than the 430,000 Medicaid people that were estimated by 2034 that would lose coverage. What are your thoughts looking at it nationally on just first the enhanced premium tax credits and why they need to be renewed now?
Yeah, no, you hit the nail on the head as to while the impact in Texas is greater than the national average, just given the fact that the enhanced premium tax credits seem to have found greater traction, no surprise, in your non-expansion states. But the rate impact is very similar. It's between the enhanced exchange subsidies and a couple of other policy changes. Analysis from, it was the Peterson Institute and Kaiser Family Foundation. They looked at rate filings this summer for roughly 312 insurers across 50 states, found that 2026's median proposed increase is 18%. That's more than double the 7% for last year. And so not only do you have the impact of people losing subsidies, but then because the insurance spikes so much for those that still are, you might start to see those who think that they may have less need for health care, look at their budgets, look at what they're going to have to pay out of pocket, elect to jump out. That also then drives premiums up because then you have sort of adverse selection occurring in the exchanges, in the individual markets. There has been talk of a bipartisan health care bill that might be taken up later this fall, once Congress comes back, probably after they get the budget straightened out, or it could be part of the budget package. One of the things that, as they talk about what could be in it, would be a renewal of or an extension of the enhanced premium exchange subsidies. Obviously, that would be incredibly expensive. I think the last estimate that I saw was somewhere in the neighborhood of 350 billion over 10. So even if they did it for a year, it would require 35 billion. So you then have to start looking around for offsets as to where the savings could be for that if Congress were to take that up, and there could be enough sort of bipartisan agreement that this is something that needs to be done.
Yeah, Chad, you bring up good points. And once again, I took the liberty. I looked at Texas Congressional District 6, which is Jake Elsey's, and 80,000 people receive tax credits currently just in that district. In Congresswoman Beth Van Dyne's district, which is a district here in Texas, that's 24, District 24, there's 62,000 people. And then in Texas District 33, Mark VC, there are 91,000 people. The point I'm trying to make, and again, this is not about which side of the aisle you're at. If these tax credits are not renewed, potentially people in all walks of districts, whether they lean one way or the other, could be impacted. Now, if the estimate of 1.5 to say 2.0 people could lose their coverage, let's pick kind of 1.7. There are 3.4 million that do receive it. If 1.7 lose it, that's 50%. And the reason I did that, I got a call from a news reporter this week and said, will you explain to me what's going to happen in Palo Pinto County and in Parker County, which is west of Fort Worth? And I said, well, 3,697 people had health insurance marketplace coverage in Palo Pinto, and Parker County had 13,000. Now, how many had tax credits? I'm not sure, but my guess is quite a few. My point is, this is really going to impact people, which brings me to my next part of my question related to looking at these enhanced premium tax credits. Chad, what do you think? If and I went online and looked, just the requested rate in Texas only, Molina wants 18.9%, which is pretty close to the median you gave. Superior wants a 36% increase. Blue Cross and Blue Shield wants a 21.1%, and Cigna wants 38.8. I know you kind of went through that and you came up with an average, but here's my point. If the premiums are going up and people lose their tax credits, the people that migrate out in many cases are going to be healthier. And then from an actuarial point of view, you're going to have people where the risk pool goes up. It brings back memories of the old Texas risk pool. What are your thoughts on what this could do to the exchanges?
But you're right. Basically, and one of the reasons why the premiums are going up so much is the plans are pricing for adverse selection. And so they're trying to make sure that they don't lose money on these products. The other thing to think about is, let's assume the best case scenario happens. Congress comes back in the fall and they pass a bipartisan healthcare bill that includes an extension of these exchange subsidies. My guess is that wouldn't happen until November at the earliest, because Congress, like all of us, Congress likes to procrastinate. So probably November, December. That's going to be too late. Rates will be filed. People will be shopping on the exchanges. So it's going to cost the Treasury more because these premiums have gone up as a result of kind of the waiting to the last minute to do this.
Before I move to another topic, the other thing that concerns me about the insurance marketplace is now they've shortened the eligibility period for sign up. And so with the shortened marketing, shortened eligibility, I talked to a group that has done a fascinating job here in the DFW area with patient navigation. And unfortunately, their budget got cut 90%. So, with fewer patient navigators, a shortened sign up period, potential adverse selection, as you indicated. We have really got to stress to all people, regardless. So if you're a Republican or Democrat, let's please don't let these enhanced premium tax credits expire.
Steve, you bring up a great point about the shortened enrollment period. I think because that was a byproduct of COVID and has been in effect for a number of years now, I think it's incumbent on the hospitals and health systems across the country, not just in Texas, to start educating their patients about this so that the patients probably aren't paying attention. They won't understand this. They may not open the first letter they get or the first email or text. They're going to think that they've got until, mid-January to do this when they don't. So it's education, working with folks in the community, the navigator groups that you mentioned, trying to help get the word out so that people know to sign up early.
Right. Excellent points, Chad. I'm kind of going down my list here and your list, but I want to make sure, do you have anything else you want to add on site neutral payments? I know we touched on it in the 340B.
Yeah, I think one of my concerns with site neutral is, beyond what's in the OPPS rule, is that it's estimated that if you were to do a broader implementation of site neutral, so not just drug administration services, but if you were to do away with, say, the grandfathering that happened, the grandfathering that exists, or if you were to kind of move to a MedPAC proposal where you were to look at where services are most commonly provided in the outpatient setting and then price it based on that, it could save up to $146 billion over 10 years. That's a lot of money. And that could be used as an offset for the exchanges. And so we might expect to see site neutral in bipartisan healthcare legislation as a pay for. I think one of the things that has sort of made this more politically palatable is kind of a thinking that, historically the argument against site neutral that's been most effective is if you do this, we're going to lose access to care for Medicare beneficiaries in rural communities and in safety net communities. Well, last spring and then later in the fall, last spring you saw a white paper that came out that said, okay, why don't we do site neutral, except why don't we take some of the savings and put it back in through some mechanism to rural and safety net communities. And then you saw in the fall, Senator Cassidy, Republican, Senator Hassan, Democrat, put out a joint white paper together that said, yeah, we like this idea and here's how we could do it. So why it didn't end up in the one big beautiful bill, I'm unclear of, but I do think that this is something that the provider community, the hospital community needs to be watching closely, working very closely to educate their congressional representatives about what this could do to access should it go into effect.
Good point. If you look at HOPDs, what is the prospect for expansion, say, beyond the proposed change? And there you go, Chad. I put my foot in my mouth. I'll let you explain what a HOPD is.
Yeah, hospital outpatient department. You have on-campus and off-campus HOPDs. Yeah, no, that's a great call out. One of the things that is really concerning beyond the proposal in the OPPS rule is CMS asks about possibly expanding the site neutral clinic visit policy into outpatient departments on the main campus. And so that would take something that has been sort of off campus and then bring it on. Now, how they're going to do that as a volume control method, I'm not sure how that would work. So that may be subject to some legal challenge, but it is something that we are watching. I'm very concerned about.
Yeah, the other thing, and I hate to even bring it up, but there is a possibility of a federal shutdown coming, and I don't know what you think, what that'll do. Will it likely impact extenders? And you can explain what extenders are, but what are your thoughts?
Yeah, and I think we've kind of gotten into this pattern this time of year because of how challenging relationships have been between the two parties. To agree on a budget to fund the government to move forward, we end up typically with continuing resolutions, sometimes passed at the last minute. If we do end up in a shutdown, whether we do or not, it's well beyond my powers of sort of crystal balling and prognostication. But Medicare, because it's a mandatory program, will continue to get funded. You'll continue to get paid. But as you mentioned, there are a handful of extenders that Congress needs to re-up every year. Things like the now COVID-era telehealth flexibilities, the Medicare low volume adjustment, the Medicare dependent hospital program, and some things like that that are just critically important that typically ride on with the budget bill. Also, the ACA Medicaid dish cut delay typically rides on this as well. So I think as we again watch what Congress does related to the budget when it comes back, it's going to be important to track these extenders, track them individually, also track that dish cut to understand kind of maybe where the puck is going.
That's a really good point. We've talked a little bit about everything, and it's not that we're trying to be doom and gloom. We're just trying to say these are the potential impacts and the known impacts of some of the legislation. And I'll give you another good example, Chad. You think of workforce. Workforce is critical to hospitals. And most people probably in the industry know, but if you're outside of the industry, 50 to 55% of your operating expense is salary, wages, and benefits because we're a real people intense industry. But the one big beautiful bill does touch workforce because I noticed in some of the language, it eliminates graduate plus financing for people that want healthcare careers. Any thoughts, Chad, on is this going to impact the workforce of the future?
I'm afraid it will. And one of the things that I find a little frustrating about this is that no one argues with the fact that we need more doctors, nurses, and techs, right? You look at it, demographics, we're set up for a shortage. And when you think about who's going to fill these jobs, particularly when you think about nurses, particularly hospital nurses, these are not easy jobs. You have to have more STEM aptitude than the average bearer across any one of those settings. And particularly for physicians, post undergrad education is incredibly expensive. Like when I think about it, my wife went to medical school 20 years ago. She came out with $200,000 in debt. And so when you think about, particularly in rural communities where families may not have the money to help their kids go to med school, putting a cap on the dollars will limit those who might want to go to med school, particularly in those areas where we need the doctors the most. Because what we typically tend to find is that if you come from a rural area, you go to med school, you tend to go back and practice in a rural community.
Kaiser puts out a lot of good information. And it said that California, Florida, New York, and Texas, and some other states have immigrants that account for at least one of their 5 hospital workers. Without getting into the immigration discussion and not getting into any of the political ramifications, that could impact the workforce too. Would you agree?
I would agree. Regardless of administration, we've always been slow on processing J-1 visas for nurses. And, the foreign nurse pipeline has always been an important source of labor for our hospitals. The thing that I worry about is, obviously hospitals aren't going out and hiring undocumented, but when you think about housekeeping, you think about facilities management, maintenance, you think about groundskeeping. If you have other industries in your community that do hire undocumented individuals or individuals whose workforce status is questionable, when you pull those out of the community workforce, it's going to drive up the cost of labor for everybody at that skill mix, which will drive up the cost of labor for the hospital.
Good point. Before we go to some of the questions people have put in the Q&A, and if you do have questions, feel free to put them in the Q&A. I was thinking last night about this webinar. I'm so delighted, Chad, that you're with us. But, there are other ramifications of the one big beautiful bill I'm not sure people have thought about. For example, FQHCs, they really treat 31 million people in this country every year. At least they did in 2023. And they get a lot of Medicaid funding, and then they get federal funding because they treat some people that at a very low poverty level. And if Medicaid cuts occur, and that federal funding isn't increased in the other pockets they get, it could really impact their margins. The other thing this could impact is many people know within the industry, emergency departments at any hospital are essentially the last resort for insurance. You know, you can go buy a ticket to a movie and decide not to go, or you're not going to go eat at a restaurant. But if you're sick and you don't have insurance coverage, you're still sick. And so you're going to probably have to get treatment. So it's going to probably impact some of the volumes in our emergency rooms. The other thing I thought about is probably going to drive up medical debt. And I know we get sometimes horror cases about throughout the country. I can say of all the hospitals I know and our member hospitals, we don't garnish people's wages, we don't attach liens, but nonetheless, medical debt becomes a big discussion. And then I think the final thing, the overall health of the community depends on the health of the individuals. So I think there's still a lot to be seen that's come out of the big, beautiful bill that you and I haven't even talked about. And I don't know if you have any thoughts on that. And then we've got a couple of questions in the queue.
Yeah, and so the uncompensated care piece of this, you touched on it, and thank you for raising it. I think as you start to analyze the bill, think about what that will do to the insured rate, everything else that we've talked about, you do need to look at your workflows for both your uninsured or underinsured patients in terms of coming to resolve any outstanding patient account or patient balances. And I also think you need to go back and look at your financial assistance policies to make sure that they are still relevant to meet the moment. The other piece of it is for the not-for-profit hospitals, in addition to doing that, I think you need to become very crisp about telling your first capturing all of the uncompensated care that you're providing, all the community benefit that you're providing, but then being out in the community and communicating the benefits that you are providing for that tax exempt status with not only your elected officials, state and local, but also your community leaders. Because if there is an issue that comes up, Steve, to your point about, unfortunately, we process a lot of transactions, and even the best intended organizations, sometimes somebody ends up in the wrong work queue, right? It's just,
Right.
Unfortunately, it happens. So if you find yourself in that situation, you've gone out, you've built allies in the community who can help tell your story for you in a moment where maybe people are questioning why you get tax exempt status. So it's not just you telling your story, but you've got community leaders standing up for you.
Good point. A couple of questions, and the first one is not for you, Chad. The question was, will we receive the notes from this presentation, seeing that record and transcribe option is already selected? I'm going to check with Chris Wilson, who does a great job doing these webinars, and I will check with him if we'll be able to do that. I really don't know that answer, but we will certainly follow up for you. I will now go to a question for you, Chad. This question is, could you please discuss your thoughts on opportunities with the Trump administration to really seriously address some of the real cost drivers of healthcare and advance a strong focus on chronic disease prevention, food safety, and alternative health technologies?
Yeah, no, it's a great question. I think the thing that I would point to is in the physician fee schedule, there's something called the ambulatory specialist model or specialty model. And essentially, this is going to be a mandatory APM for physicians in select markets that are targeted at heart failure and low back pain. And essentially, it's going to use the MIPS pathway to make a payment adjustment based on whether how a physician who is selected for this and falls into certain specialties manages their patients. And I suspect that because, if you think about MIPS, it's in concept a budget neutral payment adjustment. This model instead is a little bit like the SNF value-based care program or value-based payment program, where the administration or CMS takes a little bit off the top to guarantee savings for Medicare. The reason why I raise that is because essentially, if they're locking in savings, if it improves quality, which it should, I would anticipate that not only would you see this model expanded, but you may even see to other conditions, but you may CMS eventually make this mandatory.
Right. We have a couple other questions, Chad, if you don't mind.
Not at all.
Chad, what are your thoughts on the chances of Medicaid dish cuts being readdressed in September as part of the 2026 spending package bill?
Again, I think this is something that we have to watch. I don't know how good my crystal ball is going to be on this. Normally most years I would anticipate that this it'll be nip and tuck, but it gets extended. I think given that there are still concerns from certain corners of Congress about the deficit, that there would be higher likelihood this year than in previous years for them to take effect. But again, I don't know, I'm not confident enough in that statement to put a paycheck down on it.
Right. Here's another question, and I know it's speculation. Could subsidy payments in HIM be transferred directly to the beneficiaries instead of the insurers? Technically, the premiums are about to go up because the insurers are receiving less federal funding.
So in essence, could you give the individual exchange, we'll call them beneficiaries, a cash stipend and allow them to go out and purchase?
Yes, I think that's the gist of the question.
I, you know, anything is possible. I think from a policy standpoint, that would not be a particularly good idea. And the reason why I say this is like, think about, we've all probably got in their mind a case where the insurance company mailed the beneficiary a check for the service. And then instead of paying their bill, the beneficiary went out and did something quote unquote fun with it, like bought a boat. So my concern would be is that if you were to give someone a lump sum payment for their premium instead of giving it to the insurance company, that it may end up someplace else as opposed to health insurance.
So, Chad, you've just been awesome. You've done such a great job. There are no questions pending. Do you have any closing remarks before Chris puts up your email and my email where people who maybe have a question could email? But I want to give you the last word.
Well, thank you, Steve. I appreciate it again. Appreciate the opportunity. This has been a lot of fun. I think I'm going to go back to my comments about the Rural Health Transformation Program, and I would encourage anyone who is interested in receiving funding from that to really, look at the legislation, understand what the state's going to have to put in its application, understand what the state can use the funds for if it's approved, look at your strategic plan, look at what Dr. Oz has said he's interested in, put a Venn diagram together of those things, start to think about how you would use the things in the center, the argument that you might make to the state, and obviously, engage CMS if you can get there, engage your local representatives, engage your state government to make sure that, you're telling the story as to how you're going to be able to use those funds to improve health in rural communities.
Yeah, it's great advice, Chad. And, I'll say one small thing as a takeaway. It doesn't matter if you're to the left or the right, it doesn't matter. But please, if you get an opportunity, talk to your local district congressman that represents you in DC and explain to them how much you support enhanced premium tax credits. That would be a big step for 3.4 million people that live in Texas. We're going to conclude, and as you can see, Chad's email and my email is there. If you have questions you want to ask, please do so. But I want to take the time to really thank Chad because Chad has just done a fantastic job today. I want to thank Forvis Mazars for the support they give us. And I want to finally thank you. Thank you for taking about 70 minutes out of your day to listen to this webinar and to participate. And we thank you for participating, and we hope that you have a great rest of the day. And Chris Wilson will give the recording of this for sure to people that registered. Thank you so much. Have a good day.
Thanks, everyone.